Today I'm going to demonstrate the intercondylar fossa Beclere method in AP axial projection. Beclere method is an X-ray examination of the knee to best demonstrate the intercondylar fossa on AP axial projection is taken. The femoral condyles, tibia plateaus, and intercondylar eminence are examined for evidence of bony or cartilaginous pathology. Osteochondral defects or narrowing of the joint space are also seen in radiograph. This is a reversal of the PA axial projection for those who cannot assume the prone position. This, however, is not preferred projection because of distortion from the CR angle and increased part IR distance, unless a curved cassette is available. These projections also enhance exposure for the gonadal region. Patient position. Take radiograph with patient in the supine position and provide support under partially flexed knee with entire leg in anatomic position with no rotation. Part of position. Flex knee 40 to 50 degree and place support under cassette as needed to place cassette firmly against posterior thigh and leg. Adjust the cassette as needed to center IR to mid-joint area. Next is we have the intercondylar fossa PA axial projection in Campconventry method. This projection best demonstrates open intercondylar fossa, posterior inferior surface of femoral condyles, medial and lateral intercondylar tubercles of intercondylar eminence and knee joint space. An intercondylar fossa projection may be included in routine examination of the knee joint to detect loose body or joint mice. The projection is also used in evaluating split and displaced cartilage in osteochondritis dissecans, also to identify flattening or underdevelopment of the lateral femoral condyle in congenital slip patella. Patient position. Prone position with the pillow under the head for support and adjust the body so that it is not rotated. Part of position. Flex the patient knee to either a 40 or 50 degree angle. Rest the foot and ankle on a suitable support and center the upper half of IR to the knee joint. The CR angulation projects the joint to the center of the IR. A protractor may be used beside the leg to determine the correct leg angle and adjust the leg so that the knee has no medial or lateral rotation. Next is we have PA axial Holmblad method in standing position. This projection best demonstrates the intercondylar fossa of the femur, femoral condyles, tibial plateaus, and intercondylar eminence. It is useful in evaluating for bony or cartilaginous pathology and narrowing of the joint space. Patient position. Keeping in mind safety, the patient can be placed in one of two positions. In both approaches, the patient leans on something for support. In the standing position, the knee is flexed and placed in contact with the front of the IR. In the kneeling position, the knee is on the table over the IR. Next is we have PA axial Holmblad method in kneeling position. Part of position. For both position, the IR should be placed against the anterior surface of patient's knee. The IR is centered to the apex of the patella and the knee is flexed 70 degrees from full extension or 20 degrees difference from the CR. For the kneeling approach, the patient kneels on all fours. The IR is placed under the affected knee centered to the popliteal crease and support should be placed under the affected ankle and leg to reduce pressure on the knee. And the patient should lean forward 20 to 30 degrees and this will result in 60 to 70 degrees of the knee flexion. Next is we have PA axial projection Holmblad method on stool. Patient position. The patient is partially standing with affected leg on a stool or chair. Part of position. The intercondylar fossa should be appear in profile, open without superimposition by patella. No rotation will be evidenced by the symmetric appearance of the distal posterior femoral condyles and superimposition of approximately half of fibular head by tibia.